Good afternoon. It is my very great pleasure to welcome you all to today's lecture. This lecture, as you know, is one of the academic highlights of our year and of the department. And I first would like to thank Harriet and Arthur Aufses for endowing this wonderful lectureship, and especially for their friendship to me and everybody in the department and institution-wide. Thank you very much for this wonderful event. This year we have a truly wonderful speaker, and it is my great honor to introduce Dr. Harvey Fineberg, who really doesn't need any introduction. He currently holds the presidential chair at UCSF, but until this summer was the president of the Institute of Medicine. Before joining the IOM, where many really terrific reports have been issued under his tenureship, he was the provost at Harvard, and before that, a 13-year term as dean of the Harvard School of Public Health. Dr. Fineberg has thought very deeply and written widely on the changing healthcare landscape, the formulation of new policy mechanisms and their implementation, and especially has done groundbreaking research in clinical decision science, technology assessment, and the diffusion of medical innovation. And I think, therefore, it's very fitting that he will be the new president of the Moore Foundation in California. This foundation, as you probably know, was created by the founder, or the co-founder of Intel, Gordon Moore, who developed the well-known Moore's Law, which shows the exponential growth in computing power over time. I won't talk about the exponential growth in brain power and brain output of Dr. Fineberg, but I know that under his presidency and creative management, we'll see many innovations in the healthcare sphere in years to come. Today, he's going to talk to us on towards a culture of health in America, and we welcome you and are very happy that you're here.
Well, thank you so very much, Anatine, for that extremely generous introduction. It really is a treat for me personally to be able to share some reflections with you this afternoon, especially under the auspices of the Aufses-Whitman lectureship. And I do want to add my thanks to you, Arthur and Harriet, for your benefaction that made possible my being here, and over the years, for the community to experience such a wonderful roster of speakers. I happened to meet with a few of the faculty earlier today, seated in a room that just happened to have on the wall a plaque with a roster of the previous lecturers. And I have to say it's a very eminent group to be joining. And I knew I'd actually have to deliver the lecture because my name was already up on the wall. So there was no backing out at that hour, and here we are. I chose for my topic a subject that I've been thinking about directly and indirectly for many, many years, and a subject which is in a way both surrounding us and ignored by us, deeply immersed as we are, most of us, in the delivery of clinical care, in the conduct of our research, in the teaching of our students. But I want to take some time today to reflect with you about the state of health in our country, in the United States, on the questions about what can we do to think about the meaning of a culture of health. What is that? What would it mean? And what are the obstacles to attaining that, if we agree it's a good thing, and we'll have a chance to talk about that. And what are some of the opportunities to try to advance in a direction of a culture of health? I want to begin by asking a question. How many of you believe that America is the healthiest nation on the planet? Okay. How many of you believe that America has the finest healthcare system on the planet? Well, this is New York. It's a very sophisticated audience. All right, now here's a question. Suppose you had a serious ailment. How many of you would prefer to get the treatment for your condition here in the United States? Everyone seems now to raise your hand. Now, I find that all very curious. It wasn't, 60-40 or even 80-20. This was pretty much all or none. And I want to think with you about what I think is a kind of a paradox. Where does America stand in the world on health? Well, there is one related measure in which America is clearly a terrific, outstanding performer. That's on cost. Our costs per capita on health care, on average, is double what the rest of the OECD countries' average is. We're about 50% more than the next most highly, lavishly spending countries. So we spend really a lot. Now, if you plot spending per capita and against that look at life expectancy achieved by each country, there's a kind of regular function that you can draw, shown on this figure, that relates how many more life years do you get on average by spending more on health care. There is, however, one outlier, circled where the expenditures do not deliver commensurate benefit, and that is the United States of America. Now, when you look at typical measures like infant mortality, the United States is the last of 17 peer countries, and amongst the 30 plus in the OECD, it's just ahead of a couple like Lithuania, which is not always the company we like to think we belong in. What's very interesting is if you look at the trends over time in infant mortality, it is true that the United States has improved. In fact, we have lowered infant mortality by about 20% over the 20-year period from 1990 to 2010. But other countries, on average, began with worse rates and then accelerated below, in this case, therefore ahead of the United States over the years. Injuries, a very common source of disability and premature death. In the US, we have the highest rate of injury from transport accidents across all of the peer countries, and the third highest, again, across all the OECD countries, exceeding here only Mexico and Russia. If you look at, again, the same pattern of mortality from transport accidents, the US has gradually improved. You can see that the US declined by about 11% from the mid-70s until the late 2000s. But other countries, which started in a much worse position, accelerated even faster in improving and reducing mortality from transport. There's a pattern. The US started ahead, spent a lot more, and ended up not performing as well. And this can be seen again and again and again. violent injuries, this is a slide that I put up to guarantee that I won't be asked to be Surgeon General of the United States. This is a slide which suggests that the U.S. homicide rate is more than double what it is for OECD countries. And in the U.S., homicides 3 out of 4 times are committed by handguns, and only 1 out of 5 times with handguns in other OECD countries. Now, here's a very interesting observation that emerged from a study at the Institute of Medicine looking at U.S. health in comparison to other countries. And this observation was to answer the question, well, isn't this because we have a much more economically diverse population? Our performance is pulled down on average by the fact that we have a lot of poverty. Well, it is true that our average is pulled down by those who are economically disadvantaged. On average, their health status is considerably worse. But when you look in comparison to other countries, and you just compare the relatively wealthy Americans to the relatively wealthy individuals in other countries, the same still holds true, that we fare, on average, less well. So one specific fact, if you take non-Hispanic whites and mothers with 16 or more years of education, our infant mortality is still higher than those with comparable education and attainment in other parts of the world. Now, you don't have to look around the world to see these comparisons. I came this morning by train from the center of Washington, D.C., Union Station. I'm sure many of you have visited Union Station. Well, not far from Union Station, in the center of Washington, D.C., life expectancy at birth is about 77 years. But if I had gotten on the metro instead of on the train here and just gone 5 or 6 stops out to Fairfax County or up to Montgomery County or Arlington, the difference would have been 6 or 7 years of life expectancy just by taking the metro. Now, the answer is not we should put all pregnant women on a metro. But these are very telling differences. I was talking with Larry earlier about a group of scholars in the Clinical Scholars Program. They're meeting in New Orleans. There's also a meeting in New Orleans going on now, the American Society of Tropical Medicine and Hygiene. They're talking about Ebola and malaria and dengue and chikungunya and all the other diseases around the world. But if you go to New Orleans and you go to the French Quarter, you have a life expectancy now in the 50s as compared to going out to Lakeview, where life expectancy is about 80. So within the space of a couple hours drive within the United States, we have disparities that are essentially as great as between the wealthiest and the poorest countries in the world. So it's not only a question of comparisons to others, it's also a question of what about our internal comparison and the whole of our population. Now, this is a very interesting figure which I wanted to share with you from an analysis done by Betsy Bradley and Lauren Taylor about expenditures in different countries when they totaled health expenditures and other social expenditures, education expenditures, social support systems, other ways of providing social support. Interestingly, although the U.S., as we pointed out, far exceeds others, it's shown in blue here in the middle, far exceeds others in terms of the health expenditure. When you add health to the total social expenditures, the U.S. is more in the middling position compared to other countries, and you begin to get some sense that perhaps the real paradox is partly resolved when you consider the total investment in social support and health relative to what it does for the lives and quality of life of people. Basically, while no country spends the fraction of GDP on health, many countries spend a total of health and social investment that exceeds the proportion in the US. And it means net that health is actually more than just about health expenditures. So, how does all of this social, economic, and other force express itself in differences in health? Well, an important final common pathway for the expression of unhealthful outcomes are unhealthful lifestyles, unhealthy choices. And it's not as if there's an infinitely long list of lifestyle attributes that have relevance and bearing on health. In fact, the majority of premature death from chronic disease can be related to 4 basic lifestyle choices. First, still and foremost, tobacco. Second, diet, which is so fundamental as a factor in our overall health, in the rise of obesity in the United States, in the rise of diabetes, in the difficulty that people have in managing their daily lives. Physical activity, which is the counterpoint of diet, and use of alcohol and drugs. Alcohol is so interesting as an agent relative to tobacco, in which most of the studies with tobacco are pretty consistent that 1 cigarette is worse than none, and 2 are worse than 1, and 3 is worse than 2, and the more you smoke, the worse it looks for your health outcomes. With alcohol, it doesn't look like it's a purely linear relationship, because there are some protective effects from moderate amounts of alcohol from a cardiovascular point of view, and the other toxic deleterious effects do not overcome those benefits until consumption reaches a certain level, which is less than most teenagers think, but which is still a reality epidemiologically and makes the story and messaging about alcohol a little bit trickier than it does about tobacco. Now, here's a fundamental truth. We will never cure our way to a healthy population. We just cannot do it. It doesn't matter how many gastric banding surgeries we perform. We're not going to get to a healthy population. We're not going to get to a healthy population if we allow disease to take hold and then work our magic to retrieve and to save those who are afflicted. The only hope, if it is indeed our aspiration, to attain and maintain a healthy population is to prevent disease before it starts, and to do it in a way that doesn't just affect the few of us who are lucky enough to be at Mount Sinai, or those who are wealthy enough to go wherever they want to go, but to do it in a way that affects the lives, the choices, the well-being, and the health of every citizen. So what does that take? What would it mean if we were to say we're serious? We would like to achieve a healthy population. Well, if that's our goal, I would submit that there are, to me, 5 key dimensions to what would constitute a culture of health, a culture that reinforced, encouraged, and supported those healthy choices, that countered the unhealthy risk factors that are otherwise surrounding and infusing our lives, and that would enable us to protect and preserve the health of everyone. First, I call it choice without decision-making. Many of the gentlemen here today put on a coat, a suit jacket, or a sport coat. Some of us even added a tie. I can tell you, well, not that many of us added a tie, actually, but thank you, sir. Excellent, and an excellent choice, as a matter of fact. Well, what was the choice? The choice was which tie to put on. Now, you had a very easy time if you're going to be walking around with a white coat, everything goes, so not much of a problem, but you had a preference for that day. But you didn't actually think about whether to put on the tie. That was a choice without decision-making, because that's what you do when you dress professionally to go to your job. You put on a tie, or a sport jacket, or a coat, or some other garment that is appropriate for our culture and is simply the way we dress, whether we're going to work or we're going to play, whatever we're doing. We don't really think about making that choice. And when we're doing things for health that are easy, that are natural, that are not thought about as having to choose, that is when we start to make the conversion to a culture of health. The healthy choice is so easy, so natural, so readily at hand, that it doesn't require us to think about it and to make a conscious choice about it. Secondly, a culture of health would recognize the message of that slide I showed you about social as well as health investment. Many choices in policy impinge directly and indirectly on health. If we want to have a culture where health is reinforced, then we want to have not just health policies that provide care to more people when they're sick, but we want environmental policies that protect people against ailments. We want urban design policies that allow people to use their bikes or to walk instead of always having to get in their car and drive to wherever they want to go. We want agriculture policies that will produce and encourage the kind of fresh fruits and vegetables that are healthier for us than many of the foods that we otherwise will eat. So health in all policies is a way of not insisting that everything is about health, but awareness of the health consequences in all of the policy choices that we make. Third, and this relates directly to what can we do working and based in a medical care delivery system, that is also a critical component of a culture of health. Indeed, some people have observed that when you make the grand tour to Europe, you visit the great cathedrals. When you make the grand tour to the United States, you see the major medical centers, which are our highest cultural expression of achievement, of science, of caring, of human connection. Well, we have a lot of improvement in our performance still ahead of us. Efficiency, which is the relation of quality and cost, we're making some progress, but the cost is still really unaffordable both to individuals and to us as a society. The fairness of our system, interestingly, in the United States, a right to health has always been a matter of political debate. It's not a matter of guarantee. If you look in the US Constitution, you find very little about the individual in the body of the Constitution altogether. It's mostly about the states and the government of the federal authority. But when you get to the Bill of Rights, the first 10 amendments, you begin to see protections to individuals. And what are those protections? Freedom of speech, freedom of religion, separation of church and state, freedom of the press, the right to assemble and to petition the government peaceably, the right to bear arms, the right to protect ourselves against self-incrimination. All of these rights enumerated in the Bill of Rights in the United States Constitution are political and civil rights. They're hard-earned. They weren't all exercised from the beginning. Women did not even have the right to vote in the United States until the 20th century with the passage of the 19th Amendment. So it was a work in progress even on the civil and political front. But is there a word in the U.S. Constitution about your right to an education? Is there a word in the U.S. Constitution about your right to an old age pension? Is there a word about your right to health or health care? Not a word. All of those social and economic benefits have always, in the American context, been matters of debate, of judgment, of the body politic. And part of a culture of health will be the increasing recognition that health is and ought to be a fundamental right, and that we ought to organize ourselves as a society to protect and preserve health. That is fairness. And of course, excellence is the watchword of the delivery of service that people will benefit from. And all of these things together would make for a healthcare system that was continuously improving, what at the Institute of Medicine we called a learning health system. And that is an important component of a culture of health. I can remember when I was a child going to get a burger at a drive-in, and yes, throwing the wrapper out of the window of the car on the way home. I hope it's too late for the fine. Does any of you remember littering? We littered. When I was a kid, there was a lot of litter. We've practically done away with highway litter. In fact, today when you see someone throw something out their car window, it's shocking. In those days, it was the norm. But social expectations have changed. I recently had the experience of moving the stuff that my mother had accumulated in an apartment that she was selling. And I came upon many, many treasures. It's a nice way to express it. One of those treasures was a stack of ashtrays. And I thought to myself, I remember where that ashtray was when I was a child, where it was in the house. But today, would we have an ashtray in our homes? Most of us would not really expect our guests even to ask anymore, is it okay if I smoke? We would expect them to know that it's really not okay anymore, at least in many of our homes. So social norms do change. Social norms can be positively reinforcing, but they take time, and they are partly education, partly government decision-making, partly the experience of people coming to recognize what is or is not good for us as a community. But healthy social expectations, reinforcing those good choices and healthier habits, the idea that we will do more exercise in our daily life, the idea that we do not smoke, etc., these are a critical part, too, of building a culture of health. And finally, I add the connectedness between us, because in the end, what really sets apart healthy communities from unhealthy communities is the degree to which people feel an integral part of their surrounding. And this rather nostalgic photo happens to be from Baltimore, sitting on the stoops, but if we went to Brooklyn, we could probably have gotten photos of the same character at the same time. It's a bygone era, but it's very interesting that in a city as great as New York, what people really think about is their neighborhood. It's a metropolis of villages. And it's a very important part of feeling that you have a place and that you are connected and that you will be part of a community. Now, there are many obstacles toward going toward more of a culture of health. I summarized the big ones in the first as ignorance, apathy, and nanny state fatigue. Some of you may remember Mayor Bloomberg. Well, yes, with great fondness, I can tell. And I admire Mayor Bloomberg enormously because I would say that in his term, he did more to move the city and the nation, and indeed cities around the world, toward a culture of health than any other civic leader that I can think of. He did it courageously. He did it without any remorse, and at least in his second term, without any consideration of election. Now, there was a wonderful story that Tom Frieden tells, now at the Centers for Disease Control, but at the time Commissioner of Health, the first commissioner to work with Mayor Bloomberg, coming for his first meeting with the mayor. And Tom had decided that something that was very important to do would be the ban on smoking in bars and restaurants. And his advisors had told him this is really going to be controversial. I mean, people were talking about, diners are going to go to New Jersey. They're just not going to stay in the city. If you want to get a drink after work, you're going to leave and go to Connecticut or something. They're just not going to tolerate this. And so he was armed with a whole ream of studies and data, and he came into the mayor, and he said to the mayor, here's the case. I would like to propose that we ban smoking in restaurants and bars. The mayor said, I have one question. Tom said, what is that? He said, are you sure this will save lives? And Tom said, yes, I am. And the mayor said, then do it. And Tom was kind of taken aback, and he started to stammer a little bit, and he said, but this is going to be highly controversial. There are a lot of people who are complaining, and the mayor cut him off. And the mayor said, Tom, the first rule of salesmanship is once you take the order, leave. Now, I was thinking about that myself because in my first year of school, in college, I spent the summer working as a salesman of encyclopedias and great books. And in the mornings, because that was not a job you could do in the morning, that was afternoon, late afternoon, and evening. In the mornings, I volunteered for Head Start. This will date me, but that was the very first year of Head Start. So the first morning at our Head Start group, we had these three, they're 3, 4, and 5-year-olds. We had them sit around a table, like a little kindergarten table. And a colleague and I had brought some graham crackers, we thought, as a snack. So we put out the graham crackers, and we had some milk. And I was just astonished to see that every one of those graham crackers were gone like within 20 seconds. I mean, they were gobbled up. So we conferred, and the next day we bought some graham crackers, and we brought some other snacks, and we brought some juices and some milk. And the same thing happened again. The food was gone in a matter of seconds. And it dawned on me by the third day that these children are hungry. Now, why did it take 3 days for it to dawn on me? It took 3 days because if you grew up in my household, you could not leave the table without expressing your complete fullness. And I mean, it was an act of love to eat. And so that's what you did. So for me to find 2 miles from where I grew up, a group of children who didn't have enough to eat was just totally eye-opening. And actually, as I think about it, those two experiences really set the path for my thinking and my work in public health and about a culture of health. Why? Because it's all about sales. That's what a culture of health is all about. And the purpose is to solve the problems at their root and not to let them mature and develop. There are obstacles beyond attitudes and fatigue on the part of people. There are commercial interests. Did any of you see the congressional hearing with the presidents of the tobacco companies testifying before the Congress on whether tobacco was addictive? And one after another said no, 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 no. Now I ask you, is it possible they really believed that? And I would say yes, it is possible, because we can convince ourselves of almost anything. But that doesn't make it correct, and it means that commercial interests can be diametrically opposite to our health interest. When we see the Ebola outbreak and we notice that the burial rituals where the families touch the bodies is so obviously a problem, but do we think about the things that we do every day in our lives that are equally entrenched? From a social point of view, I can tell you it's easier to notice a pebble in your neighbor's lawn than a boulder sitting on top of your own house. And here's some examples of ways that people have noticed and made a difference. This is a case of Rebecca Oney. Rebecca was a sophomore in college, and she visited a health center in Boston. And what she found when she visited the health center is that people didn't only need pills, they had problems in their lives. They needed rent money. They needed someone to pay the heating bill. They needed healthy food. She didn't just lament the problem, but she started an enterprise called Health Leads. And Health Leads now involves thousands of college undergraduates trained and working in conjunction with clinical care to literally prescribe those other things, the heat, the food, that people need to maintain their health. So Rebecca acted, and she's making a huge difference. I mentioned Mayor Bloomberg, who's such a prominent example here, but if you want to talk about ingrained cultural traditions, let me introduce you to Reverend Michael Miner, who works in a Baptist church in Hernando, Mississippi. Now, Reverend Miner decided that the church suppers were unhealthy. And he said, we are not going to serve fried chicken anymore at our church. Now, I don't know if any of you come from the Southern Baptist tradition, but if you're talking about eliminating fried chicken from church, that is very much akin to telling people how to bury their dead. And he's doing it. If you go down further south to Brownsville, Texas, a border community, Dr. Gowan in the community was aghast to recognize that the total population, 80%, were overweight or obese, and more than 1/3 of the population was already diabetic. And she didn't just accept that. She mobilized the community and the leadership to begin to put health in all policy in the community of Brownsville. And bike paths, healthier food, making things available, easier, choices without decision-making was the result and her solution. Now, I know some of you are doing research about asthma and the treatment of asthma in the emergency room. I want to tell you another example that points to an important integration of medical care and public health. And this is designed by a company now called Propeller Health. Propeller Health created a compound device that is an inhaler and a GPS placement device built into one. And they designed this system so that every time a patient would use the inhaler, the use of the inhaler, where it was used, would be transmitted to a central cloud-based data system that would transmit the information both to the relevant doctor for the patient and to the public health authorities, so that this system simultaneously can enable earlier intervention to keep patients from accelerating to the need for emergency visit, and it can also give public health authorities indications of where geographically air pollutants or other problems are creating a special challenge for those with asthma. So it's quite a creative approach using existing technologies in a newly compounded way to provide better care that prevents complications for individuals and also provides public health value. So what can we do as health professionals? I think there are at least 5 key things. First, we can work continually to improve the health care that we deliver, which here I know you are doing, and where the opportunities still abound. We want a system that delivers simultaneously the 3 E's: excellence, equity, fairness as well, and that gets us to efficiency, which is high value for the cost. We want to bring medicine and public health closer to one another that can enable us to put more stress on the prevention of disease, as exemplified by the Propeller Health example. We want to be able to build the coalitions with employers, civic and political leaders, and I might add with the philanthropic foundations, because the Robert Wood Johnson Foundation, for one, has taken this concept of a culture of health and pushed it front and center as an organizing principle for its philanthropy looking ahead to the next decade. We want to be able to learn from the successes and achievements of others, whether it's international or around the corner. We want to be open to take those lessons, discover what they are, apply them, amplify them. And finally, I think it's up to us to take responsibility, not only for the care of an individual patient before us, but also for the health of the population we serve. A dear friend of mine, Jonathan Mann, who was the first director of the AIDS program at the World Health Organization, made an observation that some people say there's no use trying to change the world. But, Jonathan went on, if we don't try, will it change? Thank you very much.
We have time for a few questions. David, as the president of the hospital here, what were your thoughts on
I think David got stuck as soon as I mentioned the tie, and that was
It's okay with the tie.
All right, good.
Okay. I rarely need a microphone. Usually my voice carries. I think that one of the challenges we face is we live in a budget that gives extremely narrow margins.
Yeah.
And so our ability as a health system to invest in innovative ideas is very limited. Unless we have brilliant scientists like Anatine who are able to get grants that push us in that direction, it's really very challenging. Is there any suggestion that you would have to the medical centers of this nation, the academic centers in particular, and especially those that are stressed by all of the limited margins, how we should approach these problems effectively? Because I agree we should try to change things,
Yeah.
but how do we get there in an era where I struggle to make the budget even a positive budget every year?
I think it's a genuine dilemma, and I would say, from my vantage point, it's not possible to do it in isolation in a single medical institution. But here's what I would say. New York City and the surrounding communities is a defined population. What would happen if the several academic medical centers were able to get together to say, we all draw patients from all these areas, we understand that, and there's a lot of mapping as to who's poaching on whose territory and how many people are going where. We know exactly where patients are currently going. But setting that aside and using it, what if we took a perspective that we are collectively responsible for the health of this entire population, not just for the people who find their way to our doors? What if we reached agreement on where we would each take geographic responsibility? What if we then went back to CMS and went back to the insurers and said, we have a different package to put together for you, and we're going to try it in a certain way. We're not going to just do it whole at once. We have an experimental model. We're going to work on this for 3 to 5 years. We're going to test whether it's possible in this part of East Harlem to do it, and we're going to see what the rates of hospitalization become, what the total costs become, what the health status becomes. And if this proves out, and we're still willing, and you're still willing, maybe we can reach a wholly different model of the role and compensation for us as major academic centers. And if that were possible, that would mean the revenue base would not depend on services delivered. It would depend on results achieved.
We are sort of trying that as a state with the DISRIP project. You
Yeah.
may not be as familiar with it from a distance.
Yeah.
But there's an $8 billion amount of Medicaid waiver. And the governor has put together a plan where all of these agencies are coming together, and there's an entire alphabet soup of new abbreviations, which I cannot remember from moment to moment. But it essentially means that we have to create coalitions. And we're involved with unions and nursing homes and all sorts of providers, public and private, try to do this. But still, they're competing groups.
Yes.
Even just today, there was a major problem because SUNY downstate failed its own financial, health level
Plan.
to be able to be the center of this.
Yeah.
And so I think that New York is trying to do that, and government is trying to give us the carrot.
Yeah.
But it'll be challenging to see what that does, because the theory is you're supposed to make the population healthier, have fewer hospital admissions, but it doesn't necessarily come up with a sustainable model that takes you beyond the turn. You bend the cost curve, but then what? And I think that's the only question that I have with this.
I think it's a fair and important question to know whether it's a good deal for you. And the way it becomes a good deal, it can be a win-win-win, because it can mean that the institutions can gain more resources, assuming there's real savings, which I believe they're there to be had. So the institution could still gain more resources to do the things that the institution should do, which includes research and includes teaching as well as clinical service. And the payers will gain, because even though they're giving more than the institution would otherwise get for those other things, they're still paying less overall because the health of the population has improved that much. And the population gains because it's in an environment where actually it's easier to be healthier. So I would say it obviously is not easy, or people would have done it. And there are many, many interests, but I think that the more we can look to and agree on a global goal as a premise, and a sharing of responsibility. If we can get those two premises established, then I think you have a chance, even with the ornery colleagues you have to deal with, of reaching a mutually beneficial agreement. And I hope it will be possible.
Eric?
Please wait for the mic. We're recording.
I'd like to challenge your premise that you can't cure your way to health. Because I think that that is a large part of our healthcare system still. If I look at my own personal history, I look at at my parents now that are 85 years old, both. My father's response whenever he's asked, how are you doing? He says, I'm doing very well. I'm between illnesses. And if I look at all those sagas, maybe not cured, and at least for some of his illnesses, I think they cannot be blamed on, certainly in his case, not tobacco, not overeating, or the like, certainly cultural issues maybe around atherosclerosis and the like. But I think there is a component of still curing our way to health that we can't disregard. So for example, Alzheimer's disease, which is arguably the new rate limiter, we have to be able to do something different from what we're doing now with Alzheimer's. And it's not just prevention. So
I'm very glad you mentioned this, but I do want to go back to that slide, if I could here, because there's an important word. We will never cure our way to a healthy population. That is very different as a proposition than we can never cure illness in any individual. In fact, we can and do, and we're thrilled. And we should be, whenever we succeed with every individual. My point is that if our strategy depends on every individual's illness being cured, we're never going to achieve the kind of population-level health that we deserve. They're not mutually exclusive, fortunately. All that we do about prevention actually frees up resources to do more intensive intervention for those who do fall ill. So paradoxically, from an economic point of view, we'll improve our ability to invest and cure when we do more to prevent illness in the first place. Because when it does occur, it occurs less frequently, it occurs in ways that we can manage more readily, economically, and it's not at all inconsistent. So I'm glad you brought that up because that is a very, very important distinction. It explains why everyone in this room voted that they would stay in the U.S. to get their personal care if they had a serious illness, even though no one believes that we have the best health system in the world, much less the best health. And that's explaining the difference. I don't see why we can't have both. Yes, sir.
Wait for the mic. One moment.
I'm Dr. Block. I'm an old-timer here. Dr. Fineberg, this may be a different lecture, and please tell me it'll be a different lecture. But how do other countries do it? How does France, with a lower economic level, achieve such success, and when we can't? Is it just a basic difference in population expectation or government intervention? I know their budgets are great deficit yearly in healthcare. I know about that, but is this a different lecture or is this an appropriate question?
It's a very good question, and it is another lecture, but I will say very briefly that the difference is not in the excellence of the very best institutions of that country compared to ours. It's not because France can send more people to a higher quality hospital to get their care than the US can. That doesn't account for the difference. They can't, and they don't. So that's not it. But this report that I alluded to on America's place in the world in health that the IOM did really is an attempt to systematically look at the evidence to try to answer your really cogent question. And really the best that the committee could come up with after examining a lot of the evidence is the emphasis on the kind of social determinants and behavioral differences that contribute to better health that many countries invest more and more consistently in than does the U.S. So that was a big part of it. Now, on the cost, there's another element that we experience. I don't know, many of you are much too young, but some of you have gone through applying for Medicare. Anybody do that for a parent, perhaps, or a loved one as well as yourself? Now, you're experts. I defy you to be able to work your way through that system without consultation and advice. And if you, heaven forfend, need to change insurers, then you're going to be talking to a minimum of 3 and usually 6 people in different agencies. Now, what does all that mean? That means that there's a huge administrative overhead to our multiplicity of systems that is a part of the cost we pay for choice of insurer. I actually think most people want choice of caregiver. They don't really care that much of who's paying the bill, but that's another story, and that's definitely another lecture. The key here is that another big part of the U.S. disadvantage is our administrative overhead.
Dr. Fineberg, I loved your talk. I want to suggest something about the word choice that's a semantic nuance. When one talks about healthy choices in the context of choices but no decisions, it provides, I think, the potential for ammunition for those of an antithetical bent to say that those who are unhealthy are making unhealthy choices, whereas they may really be habits or things that are shaped by external forces and the culture as you speak. And I wonder if there's an opportunity to add to this leadership by also avoiding that.
How would you articulate it, Larry? What would you say? Would you say healthy actions without decision making, for example?
No, I think healthy
Or
choices
healthy
without
behaviors?
decision, or
Yeah.
I think that's fine. I think the overall context actually sets it up beautifully. It's just the one slide that said are the result of unhealthy choices, where those may really not be decisions,
Yes.
and it suggests otherwise. So I
Got
might,
it. Okay, there I think is a very easy fix. That would be unhealthy behaviors.
yeah, unhealthy behavior.
Yeah, good. Thank you.
I have a question. Where would you put education in this system?
Very high.
Right.
Very high. I mean, every study that's ever been done, especially actually about women's education in the world, has documented the benefit for health and family health of greater education. That's one of the most clearly established social epidemiological findings that there is.
Would you add another E to your
Education.
Yeah.
You mean for the health? Well, those 3 E's were for the health delivery system. I think I put education in my thinking in health in all policies, where education is a critical part of that. But thank you for the emphasis.
We have a last question before
Yeah.
Mike has to go over there.
Okay.
I thought the optimism that you displayed in thinking that our medical institutions could collaborate was misplaced. So I thought maybe you could explain why you're optimistic or how we might overcome their competitive nature.
If I were talking realpolitik, the way I would do it is to make the alternative worse. It's like it has to be a near-death experience before you're willing to think differently. But if your options are to fail or to cooperate, maybe you'll cooperate. And even then, it's not easy, but I would say that's probably what it will take.
I'd like to thank Dr. Fineberg for this absolutely wonderful, broad sweeping and thought-provoking tour de force about the social, cultural, economic, technological, medical factors that affect a culture towards health, behavioral. We would like to continue briefly the discussion over one glass of wine, perhaps.
Good idea.
And want to thank you again for this wonderful lecture.